She is the SHIP and SMP Regional Liaison for CMS Region 6. She's the team lead for the opioid crisis outreach as well as for the tribal outreach. The majority of her time is spent planning and implementing outreach and education events, as well as partnership and stakeholder development. And like I said, I've known Gay for many, many years, gone to many conferences with her, and I think you're going to find her presentation very good. So Gay, welcome.
Thank you so much. I'm really glad to be with you today.
And you got the ball.
All right. So now I am the presenter. I want to share my screen, so give me just a moment. Good morning, everybody. I'm so glad that you're here with us today. All right. I hope you feel welcome too. Please know that as we go through the PowerPoint today, if you have any questions, you can enter those in the chat screen, and we will take care of questions and answers at the end of the presentation. So with that, I'm going to go ahead and move into the presentation as soon as I see my little buttons. There we go. Okay. On here. Okay. Now then, let's see. All right, here we go. Well, I've told people already that this fall, you see how happy all those people are right there? Well, they are happy because they're going to be learning something today about what are the hot topics for Medicare for this coming year. I know it says 2020 because that's the addition of it. Most of the things we're going to be talking about, however, will be taking place in 2021 and past that time. I also see I didn't change the date, but it's October 13th in case you're wondering where I live. Where I live, it's the 13th as well. Let's see. Well, and I would like to tell you, just draw your attention to the man with the glasses. Last week, he was the only thing I could see. And I think he fell in love with me. Every time he popped up, he was smiling just like that. And it really helped me get through the presentation much, much more quickly. So if any of you feel like smiling, go ahead, although he's the one I'll see. All right, now let's find All right. All right. These are some of the things we're going to talk about today, the priorities and strategic initiatives. Original Medicare updates, those are the ones that we're always most interested in, as well as at Medicare Advantage and prescription drug updates and the marketplace. So let's move on. All right. Why are we doing this session for you today? It's because we want you to have at least a small amount of knowledge about how is it that CMS is structured again and what do they do. We want you to understand the updates for original Medicare, the changes for the MA plans. We're seeing a lot of changes in MA plans coming down the pike. And then also understand the Medicare prescription drug changes. And we do have a couple of slides on the marketplace, the health insurance marketplace as well. All right. All right. This wheel is a graphic that you've had shown to you for the last couple of years. Basically, it's just kind of how CMS's work is structured. And you see that right in the center are our patients. And that, of course, is always our main goal, is to make sure that our patients, get the adequate care that they get. They feel empowered to, make healthcare decisions for themselves. And by doing so, or in doing so, they also have the access to their records like never before. We are really big on unleashing innovation. What are the best ways that we can reach the Medicare beneficiaries and make sure that they understand the benefits available to them and how to access those? And then, of course, focusing on results. We've talked about pay for performance for several years. We've talked about other strategies that help us focus on the results. We don't want to just, have a one-shot deal where you go into the doctor, he gets paid, and good luck. We really think this might work for you. We want to focus on the results. And so we're all working together for that. All right. All right, now then we're going to start talking about some of the legislation that is in effect and may be new. You see, when it says final rule, that means that all of this, any of the edits to this have already been placed as part of it or taken out or whatever needed to happen. But we're going to talk about interoperability and patient access. And so what this is for is just establishing a standards-based application program interface, API. We know that has to do with our cell phones. And what it's saying is that our cell phones now will be able to support a patient's access and control of their electronic health information. So you can have access to your patient records for free from your healthcare provider. And so this is a requirement for Medicare Advantage, Medicaid, CHIP, and the federal exchanges to share claims data electronically with the patients. And so it's going to allow patients to access any third-party application. So depending on the phone that you have and the application that is on that phone to access your records, the patients have that, and it can be carried with them from plan to plan and healthcare provider to healthcare provider. So again, this is one way of having access to records. All right, it also requires hospitals to send electronic notifications to another healthcare facility, community healthcare provider, or a practitioner when a patient is admitted, discharged, or transferred. I don't know if this has happened to you, but I know that it happened to me. I went to a specialist and ended up having some pretty major surgery. And when I got out of the hospital, they said, now check with your primary care physician, for some follow-up. He had no idea how I had even been in the hospital. But now hospitals are required to let other providers know when you are in that facility, so that we have a greater continuity of care. Thank you. So they're going to find out when you're admitted, discharged, or transferred in case the patient goes somewhere else from there. So beginning April 1, 2022, states are going to be required to send enroller data daily for both Medicare and Medicaid. So our dual eligibles information is going to be a daily exchange update beginning in 2022. We have a lot of problem with billing. Who bills first? Do we send this to Medicare? Do we send it to Medicaid? Well, we know that Medicaid is always the payer of last resort, but maybe providers are not as aware of that. And so inappropriate billing happens, and then it has to come back, and the providers are waiting for their reimbursement for their services. So this will be one way to help cut down on some of that. All right. Now, there are some newer, updated, innovative models that we want to talk about. Emergency triage, treat, and transport. We'll talk about that one. The value-based insurance design model. There's an update there. There's an update to the kidney care choice model and ESRD treatment choices. And then also the Part D senior savings model. So let's go and look at those. All right. All right, the ET3, Emergency Triage, Treat, and Transport. This is a wonderful program. It's a voluntary 5-year payment model. So that means we're still seeing how is this going to work. But the way that it works is that beneficiaries will get the most appropriate emergency services at the right time and place. We've talked before about the fact that ambulance claims are the number one claim that is rejected by the fiscal intermediary when the claim is submitted. And it's because of several things. One thing is a lot of people don't understand the requirements for Medicare to pay for ambulance coverage. The other is it could be incorrect billing. But basically, if you call an ambulance, the only place that they're going to take you is to the emergency room. Well, not everybody may need to go directly to the emergency room. So what we're going to have is greater flexibility. If you really need to be transported to your doctor's office, they have what you need there for your treatment. The ambulance has the ability to do that. Or maybe you just need to go to an urgent care clinic for some, wound care or something like that, rather than being admitted to the hospital and all that that entails as well. And then also, ambulances will have the option to have on staff on the ambulance a qualified healthcare provider or practitioner, either in person or via telehealth, who may be able to treat the patient right that minute and they don't have to be transported anywhere. So those are part of this model that we're looking at. All right. When we look at value-based insurance, here's the model for that. Beginning in 2020, all 50 states were part of this. But one of the things that this value-based insurance design is looking at in 2021, which will be here next week, right? The model will also test having Medicare hospice benefit in Medicare Advantage. Currently, Medicare Advantage plans do not cover hospice care. If a person is in an MA plan and they need hospice care, then that care is managed by Original Medicare rather than the Medicare Advantage plan. So we see here that the performance period of this model is going to be going through 2024. So every year we ought to be able to build on what we've learned as part of that model as we go forward. All right. Models to transform kidney care. And one of the, this proposed rule again is looking at end-stage renal disease or ESRD treatment choices. And the two things that we're looking at here is that the model would encourage a greater use of home dialysis. We're encouraging people who can to manage their dialysis at home, which would be a great thing for people who have to travel quite a ways to get to a dialysis facility. I know that in New Mexico, of our 5 states, there are some folks who have to get on a bus early in the morning because they live so remote. And they'll get in on that bus, travel to a dialysis center, sometimes over 1 or 2 hours, stay for their dialysis treatment, and then have to travel home. So how wonderful if the person can be trained how to set up their own dialysis. They have a home dialysis set up and run that at home with probably a caregiver or someone, of course, assisting them. We're also going to encourage greater use of kidney transplants, hoping that people can get their transplants sooner rather than later. Many times it's kind of a last-ditch effort, just waiting for the transplants. And I'm not really sure how that all works, but that is going to be one thing. Maybe some people have a reluctance to have a transplant and maybe just need better education about it. So you see here the payment adjustments under this are going to be January 1, 2020 through June 30th, 2026. So those adjustments are already in effect, and we'll see as we go along how this program does as well. And then there are some optional payment models called Kidney Care First, the Comprehensive Kidney Care Contracting Graduated, the Comprehensive Kidney Care Contracting Professional, and then global payments. So all of those are just going to be different ways that Medicare providers bill Medicare for the services and how those are paid. All right. Senior savings model. We're going to just touch on this a little bit today. There is more information for you, but it is an option for folks to pick a plan, a Part D plan or an MA plan that has prescription drug coverage that are going to help lower the out-of-pocket costs for insulin. So the plan sponsors will offer beneficiaries choices that provide broad access to multiple types of insulin. There are 4 types that we're talking about here. One of them is just the regular slow-acting insulin. We also have fast-acting insulin I'm not really describing these very well. Give me just a second. I'm going to give you what this is. Sorry, I should have had this pulled up already. Rapid acting, regular or short acting, intermediate acting, and long acting. So, of course, your doctor works with you and your particular situation to know which type of insulin that would be. So, you would have broad access to multiple types of insulin. Providers, again, would not have just one type of insulin there. And look at the next bullet. This is the thing that I know many people with diabetes that are insulin dependent are going to be so happy to see this $35 copay for a 30-day supply in the deductible, initial coverage, and coverage gap phases of the Part D benefit. So from day one, that copay for that insulin, if you have one of the senior savings model plans, it will be $35 for 30 days. That's almost $500 savings for people in a year. What it does, it improves access and affordability of insulin in order to improve management of the beneficiaries who require that insulin for their daily care. One thing that we want to talk about for just a second, though, with the senior savings model, if you are helping someone look for a Medicare prescription drug plan or an Advantage plan, and they're interested in the senior savings model, it will be a filter on the plan finder, and you can pull up the plans that offer this. However, please help people to understand that that $35 copay for insulin may be wonderful, but you have to look at their whole medication package, because they could end up spending more money for their other drugs while spending less for the insulin and come out at the end of the year actually spending more. So we want to make sure that they don't get so hung up on the senior savings model that they don't look at the cost of their other medications in conjunction with that in the plan search. All right. In the plan finder, as I said, you can it includes a filter so you can know which ones of the plans do have this. And it's going to be easily noticed on the plan finder as we go forward. All right. The care compare. We've had, we were slow, I think, kind of moving into this. We had nursing home compare, and now we have hospital compare and provider compare, home health or hospice compare. So instead of having these just spread out all over the Medicare.gov website, we have one stop shop right here. And you can look at the care compare page in Medicare.gov, and then just use one of these links to go to the kind of care that you want to look at and compare in your area. So it's going to make it easier for people. And that way, if they want to compare, one thing, and then they want to come back and look at something else, then it's just an easier way for those to do that, more streamlined. All right, so those were the upcoming models that we've been looking at and will continue to look at. So now let's look at what is different for Original Medicare. What's coming up for Original Medicare with respect to updates. There's my little friend, you see him? All right, let's look at the Medicare enrollment numbers. When I first came to work for Medicare, and that was nearly 16 years ago, there were 43 million Medicare beneficiaries. Now, when we look at it, we are up to 62 million Medicare beneficiaries. 37 million of those, about nearly 38 million of those are in Original Medicare. But look at the number in Medicare Advantage plans and the other health plans. 24 million. That gap used to be huge between those who were in Original Medicare and those who took the Medicare Advantage coverage. So if you go into this Medicare enrollments numbers, you see that, the color codes that we have here, 300,000 to 5,999 people in Oklahoma have Original Medicare, and I'm sure that's higher now because we've had several people have a birthday during that time. since this map came up. But if you look at it, you see that you can sort by either original Medicare, Medicare Advantage, and other plans, and then the total. This just shows us the number of people in original Medicare. All right. Something new this year as part of the initial enrollment period, regardless of when a person either aged into Medicare or because of disability, they were able to access Medicare coverage. Whenever that happened during the year, we know that they are going to, for most part, they'll be auto-enrolled in Medicare Part A and Part B, living in the United States and lots of territories. So there's a package that's sent to them. It says, welcome to Medicare, here's your card, and you're signed up for A and B. And if you do not want Part B, you send it back, all of those things. So this is sent a month for the Medicare cover. No, I'm sorry. That's the package that's sent to people. Now, 1 month before a person's Medicare coverage starts. So they were active in the initial enrollment period early, or maybe they just started just as soon as a month before their Medicare coverage starts. They're just going to get a reminder notice. Hey, remember, your Medicare coverage starts in 1 month, and you need to look at how do you want to receive your Medicare coverage. Look at the benefits and then make the coverage choice. And so this starts mailing late in 2020. Well, we're getting pretty close to late in 2020. So you may get contact from one of the beneficiaries who's in your area that you know and work with. Say, I got this letter. I'm not exactly sure why I got this, but can you help me? And that's what it's about. These are beginning to come out now this fall. All right. In the Medicare and You Handbook, I hope that you've received yours in your offices. I know that beneficiaries are receiving them in their homes. And how, you might ask me, do I know that? Is because my husband is a Medicare beneficiary. So right inside the front cover of the Medicare and You Handbook for 2021 are new tips for people who are new to Medicare. Right off the bat, things to do now. Do you want extra coverage and benefits during this first year? Here are the things that Medicare covers for you. And during this first year, we would encourage you, of course, to get your Welcome to Medicare physical exam, and then also sign up for what preventive services that you need. And then it will tell how do you make coverage changes outside of the initial enrollment period. So these are important things that are included in that handbook. And I think the biggest challenge here is getting people to open the handbook. So we'll just want to encourage people, if you help someone sign up for Medicare, encourage them, to take advantage of what's available in the Medicare and You Handbook. All right. And again, we're jumping around here, but all these things still have to do with original Medicare. The IRMA amount for 2020 and the 2020 IRMA, which is it's like a surcharge added to the Part B premium and Part D premium, but this is the chart for Part B for this year. It's based on the modified adjusted gross income, the MAGI, for people on their tax returns from 2018. So in 2020, we looked back 2 years and assessed this based on the modified adjusted gross income of their tax returns. And we see here that for an individual or for a couple, if their tax return, their MAGI is $87,000 or less for an individual, or $174,000 or less for a couple filing joint, the standard premium has applied for them, the $144.60. Now, and you see incrementally how the more that a person's MAGI increased, or a couple's MAGI increased on their tax return, the higher their premium is going to be. But if you look in that column that says file married and separate tax return, and there are some people who do that. They're married. We file that we are married. However, I'm filing my own tax return. My spouse is filing his or her own tax return as well. You see that for the mid ranges there, above 87,000 up to 163,000, there's no incremental premium for those folks. Once they get above 87,000 in the red box, do you see how it's saying this? Above 87,000 and less than 413,000 or 413 and above, you see that they get lumped into that higher or the highest levels of the Part B premium. Now we know this is appealable. People can say, yeah, that was my income in 2018, but here it is 2020. That is not my income anymore. That was a one-time bump, maybe. I was still working then. Whatever the reason, this needs to be appealed with Social Security. We know that the extra money for the Part B premium goes into the Medicare Trust Fund to help shore it up a little bit. And so that's where that money goes. We have a small percentage, really, of Medicare beneficiaries who really fall into this bucket, but enough that it has been helpful to the Medicare Trust Fund. But if you are going to appeal this, if you or someone you know gets a statement from Social Security saying, your Medicare Part B premium will be this much in 2021, and that's above the Part B premium, that can be appealed with Social Security, but do not neglect to pay the premium, the higher premium, until that appeal gets worked out. Because if you don't pay your premium, you could lose your Part B coverage. And you don't want to have to do that and go through what it would take you through to have to enroll then during a general enrollment period and wait on coverage. So that's what this chart is all about, though. It shows people, with the higher income, and then also those that are filing separately. Those are the changes on this. All right, here's a new option. People can pay online for their premiums now. So they could pay their Part A premium if they're a person who is purchasing Part A or paying part of the premium because of their work history, Part B premium, or Part D IRMA premiums. And we know that Part D IRMA premiums then would follow the same structure as the Part B IRMA. And we'll look at that in a minute. This is not used for your Medicare Advantage or the prescription drug plan premiums. We know those go directly to the plans and not to Medicare at all. But if you want to sign up for online premium payment, you can get this through your bank, just like your bill paying option that you have on your bank, or pay with your debit card or a credit card. But you'll get a confirmation number when you make it. It's a secure site. And it will say a payment was made to CMS Medicare on this statement, so that you will know what that charge is for until you get used to seeing it there. All right. Changes in 2020 for medigap. Well, we are aware of those because we've been dealing with them this whole year. We know that standardized plans C and F for newly eligible people with Medicare, that began January 1st of this year, and it goes forward. Or for people who get premium-free Part A as of January 1st, 2020 or later. So anybody getting Part A as of January 1st, anyone newly eligible cannot purchase a standardized plan C or F. Now, a person who wasn't newly eligible, is already in Medicare, can apply to buy a plan C or plan F. But this is not a guaranteed issue. The plans have the option to sell you one of their plan options anytime that they want to, but you have to know that the protections that you get during your Medicare Open Enrollment period would not apply then to this Medigap change for Parts C and F. So the insurance can also get those retroactively if they want to do that, if their start date was before January 1, 2020. So I hope I didn't confuse you with my stumbling around with this one. This is an important change, though, to the Medigap policies. All right. Therapy caps for 2020. Well, we know that the Bipartisan Budget Act of 2018 did away with therapy caps. That was repealed, which was the dollar limit that Medicare would pay for physical therapy and speech language pathology combined 2080 for 2020, and then also 2080 for occupational therapy. Now, then, we still have that limit. It has nothing to do with how much therapy that the patients can receive, but it has everything to do with billing. So, if a person's treatment for their therapy goes past that annual dollar limit, then there's a special qualifier on the billing that providers have to put in order to confirm that, yes, we are aware that, we're past that dollar limit. The beneficiary will not be charged more. But, they have to note that modifier on the payment request. So there's a targeted medical review process that will go into effect if a person's therapy goes over that limit. But you see that the $3,000 through 2028 will be the limit for that. So if their total therapy costs by, doesn't matter what month, June, July, August, whatever, and the billing is received for over that amount, then there will be a targeted review for that to make sure that the patient is, or Medicare is not being overcharged for patient therapy, and that, everything is exactly how it needs to be. All right. The new opioid treatment program benefit. We'd like to think that the opioid crisis is dwindling and going away, but unfortunately, with COVID-19, we're seeing increases in the number of people who are, classified as someone who has an opioid use disorder, and unfortunately, deaths from opioid overdoses also are increasing. So Medicare Part B is now covering opioid use disorder treatment services. There have been opioid treatment programs across the United States for several years, and many of these treatment programs have signed up to be a Medicare provider, and that means that Part B will, reimburse the provider for their program expenses for Medicare beneficiaries. So the beneficiary pays nothing if they get these services from an opioid treatment provider that's enrolled in Medicare. So it's a benefit for Medicare beneficiaries, but they do have to pay the Part B deductible. That has to be met, before they will have no payment with the treatment provider. So the different programs that are paid for through the opioid treatment program benefit are medication assisted treatment, counseling, drug testing, individual and group therapy. And then the note is that counseling and therapy services are provided either in person or by virtual delivery. And so that's an important one. That's where the beauty of a video camera certainly comes into play, because not only can treatment counselors get an idea of how a patient is doing based on what they tell them, but also how they look. People who are addicted to opioids many times just have characteristics physically that a counselor would be able to pick up on. Medicare's coverage of methadone will now be part of the treatment coverage through the opioid treatment programs. And during COVID-19, and we know that this is not just for this part of the health emergency, counseling and therapy services, as well as periodic assessments, can be covered if they're rendered by telephone. So there can be some services that can be billed, even if it is just by telephone. Medicare acupuncture benefit. Hallelujah, you say. I would think acupuncture might be helping me. But Part B is going to be covering acupuncture up to 12 visits in 90 days for chronic low back pain. And we know that chronic low back pain is defined as pain that lasts 12 weeks or longer. They just don't know what causes it. It doesn't have an identifiable systemic cause. And it's pain that's not associated with surgery or pregnancy. And so those acupuncture visits, if they are effective and the patient is receiving some benefit from that, only if it's not getting better at all or you get worse, would the treatments be started. There are 20 maximum in a year. So if you get that first 12 and up to 90 days for chronic low back pain, then you have 8 additional sessions for the rest of the year that you could access as well. So hopefully that would be able to help folks. Now, again, it's only for chronic low back pain. Medicare is not covering acupuncture for any other treatment choices at this time. All right. This is a billing slide talking about how home health groupings are put into place so that the billing for them makes more sense. We are always in the mode of making sure that we pay for performance. And with home health especially, we know we've had some bad players and, who have been sanctioned, and it's almost like a game to some of them. You shut them down in one location and they'll just go around the corner and up the street, open a new home health agency with a different name and go. So we've had a lot of fraud and investigative work with our home health agencies. And this is just another way to make sure that the payments for the Medicare person's treatment is in line with what they really need. And so that's what this is all about, is the billing for that. But it's just something for you to be aware of that Medicare is working on. All right. When a person has outpatient surgery, we know that is billed to Medicare Part B. But beginning July of this year, there are certain procedures that Medicare beneficiaries will be going to the hospital outpatient services for that are going to have a prior authorization request before the surgery can happen. We are familiar with prior authorization with our prescription drug coverage and with other surgeries, inpatient surgeries, and now we're looking at some categories of outpatient services as well. And basically, these are going to be the cosmetic services, and many times those are used because of a medical condition that warrants them. The fact that you look better when you get through, well, okay, but that's not why Medicare would cover them. So what we're looking at here is blepharoplasty, and that's an eyelid lift, the Botox injections, a tummy tuck, rhinoplasty is a nose job, and then vein ablation. All of those, in order for Medicare to cover those in an outpatient setting, it's going to have to be a prior authorization process. So there has to be medical necessity for these in order for them to happen. So you can apply for these for the prior authorization and then just appeal that with an unlimited number of appeals until you get a satisfactory answer. But we also need to make sure that the services performed in the outpatient clinic also that might be affected, anesthesiology, the physician services, and the facility services. So there would have to be a prior authorization that, that would affect all of these different services. All right. Expansion of telehealth services during COVID-19 public health emergency. We know that people who are Medicare beneficiaries usually are at a higher risk for COVID-19. And so being able to visit with their physician or clinician from their home with having to go into an office or hospital and put themselves at risk is one of the things that then the telehealth services was put in place for. So there are specific services Medicare beneficiaries can receive. We call these evaluation and management visits, and that's, I'm going to the doctor because I've got this sore throat, and the doctor examines your throat. Yes, you do, and you've got blisters on that. And so the management would be, let's do a strep test and see if you have strep throat, and let's manage this illness. So that's evaluation and management visit. Also applies to mental health counseling and preventive health screenings. Of course, we know not all of those can be done over the telephone, but some can be. So Medicare can pay for office, hospital, and other visits furnished by telehealth across the country and including in a patient's home. So this is a wonderful boon that has happened for many of our Medicare beneficiaries who are either unable to get out during the pandemic or they're just too frightened to do so. And I think emergency room visits in particular are very scary for all of us to think about. All right. Let me take just a 5-minute break, if you don't mind. My voice is getting a little bit scratchy, so I want to get through these in just a minute, but let's take 5 minutes, if you don't mind, and then we'll come back. Thank you.
I was trying to move the ball and don't seem to be able to. So while Gay's taking a break, I did want to share with you, we had a question that came in from someone who was asking, so if you want to enroll in one of these Medicare related products, Part D or a Medicare Advantage plan or something like that, how do you go about doing that? And it's different for each one of them. If you're just enrolling, for instance, if you're enrolling in Medicare itself, you're going to actually contact Social Security to get that done. And you can do that up to 3 months prior to becoming eligible for Medicare. Then, if you're talking about a Part D prescription drug plan, you can do that by going to Medicare.gov and getting that information directly from that website. Or you can contact our office. Our phone number is 1-800-763-2828. And we would be happy to walk you through that process as well. You can also go through an insurance agent to get enrolled in Medicare Part D. The same is true for Medicare Advantage plans. Those are the HMOs and the PPOs and things like that. You can get enrolled in those by contacting an insurance agent, I misspoke. We can help you review the Medicare Advantage plans, but we can't actually enroll you. You have to go through a licensed agent in the state of Oklahoma to get that done. But we would be happy to help you compare those plans and help you decide which one you want to enroll in, and then you can contact an agent. Or again, you can contact the company directly. For Medicare supplement plans, you're going to have to go through a licensed insurance agent, or again, you can contact the company directly if you want to enroll in one of those plans. However, we can, if you're interested, we do have a tool that allows us to do a comparison of the rates of the plans that are available in the state of Oklahoma, and we can run that comparison for you. And again, if you're interested in us doing that for you, our phone number is 1-800-763-2828. We would be happy to do that for you. So, Gary, you ready to get cracking again, or do you need a little more time?
I'm good.
All right, you go, girl.
All right, thank you. All right, I think you need to give the All right. We want to keep going here. We've got a little bit more ground to cover. You have been a wonderful audience. I've really appreciated you smiling at me as we're going along here. Let's talk about the Medicare Advantage updates next. All right. Here's the biggest one that's been talked about so much, and that is the expanded health-related extra benefits Medicare Advantage plans. Many of these have already been put into place, but for a primarily health-related benefit, we're looking at a benefit that's used to diagnose, prevent, or treat an illness or injury, compensate for physical impairments, which would be, your durable medical equipment, improve the functional or psychological impact of injuries or health conditions, and reduce avoidable emergency and healthcare use. So we know that these benefits have to be focused on the enrollee's healthcare needs and recommended by a licensed medical professional as part of a care plan. But again, these are primarily health-related benefits. Now then, beginning in 2021, Medicare Advantage plans may offer additional benefits. No, that's not true. Medicare has already offered some additional benefits. Of course, that's the advantage of the Advantage plans, right? But we're going to be looking at additional benefits that are not primarily health related. They're for chronically ill enrollees. So these will not be available for everyone, but for chronically ill. When the additional benefits have a reasonable expectation of improving or maintaining the health or overall function of the chronically ill. So you see here that we're looking at treatments that can improve actually, just the daily living for these Medicare enrollees. So what are some of these primarily non-health related items that we're looking at? Home delivered meals, food and produce, that could be fresh food, packaged meals, it could be frozen, canned food. This would not include alcohol or tobacco, as best we understand. Those are not included in food groups, but it is more than just a Meals on Wheels drop by. This could be groceries delivered to the person's home. Complementary therapies, that would be like acupuncture or massage, can be available through one of the Medicare Advantage plans. Transportation for non-medical needs. That could be transportation to a doctor's office, could be for religious services. It just depends on how the plan structures that transportation. Services supporting self-direction. This is a service, it's really kind of like a guidance service. This is for folks, I want to make my own Medicare decisions. And this is a way for someone to sit down and say, okay, you're wanting to look at perhaps changing providers, or you're wanting to look at finding a new home health company, something like that. And so it's a one-on-one type service, really, to help people know how to access all of the benefits available to them and how to make those changes. That's what that's about. Pest control, it's hard to get better or feel better when you've got pests in your home. And I'm just talking little critters. But, that's an important part of that. And many insects and rodents bring disease into a person's home. So that pest control is huge that for some Medicare beneficiaries would be available. Structural home modifications would be maybe a wheelchair ramp or widening a bathroom door, something like that. Indoor air quality equipment and services. This could be anything having to do with your air conditioner or a humidifier or a dehumidifier. Could be cleaning the drapes and the carpet because of the dust mites that are in the carpet, and it would make the air more breathable inside that person's home. General supports for living. This has to do with helping a person make some decisions. If you're looking at moving into a retirement community or a nursing home or a skilled nursing facility, different supports, then general supports. This is helping people make those decisions. But it also could be something like paying the utility payments if a person needs help with that in order to stay in their own home. What is it going to take for that to happen? And then social needs benefits. We know being in isolation is so hard on all of us, but particularly for folks who are chronically ill, who are isolated, feeling like from the world. And so there are some plans that are going to offer social needs benefits, like membership maybe in a club, not just a health club, but maybe just a special interest club that this person would like to join, that the plan would provide that. It could be counseling. The person needs personal counseling or family counseling, marital counseling, something like that. But there's just a variety of things when you talk about social needs that the plans can offer. These are just some of the kinds of supplemental benefits for the chronically ill that Medicare is paying for through the Medicare Advantage plans. There's also going to be that there's a policy modification basically that says that the chronic conditions that CMS had in the care manual are not the only ones that are chronic conditions now. And so there may be other chronic conditions that can meet the statutory definition. So beginning contract year 2021, CMS is allowing plans to target other conditions in order to do that. So let me just tell you what some of the conditions that are already in this Medicare Managed Care Manual: rheumatoid arthritis, cancer, cardiovascular disorders, dementia, diabetes, and end-stage renal disease. So all of those are conditions that can be considered as part of the Medicare Managed Care Manual. Step therapy for Part B drugs and Medicare Advantage. We know that we've had step therapy for Part D drugs, and now this is going into some guidance that MA plans can use a step therapy for Part B drugs in the 2020 MA and Part D drug pricing rule. So what we're trying to do is achieve the goal of lower prices by making sure that people get the medication that they need. And so we know that with step therapy, the physician may have to verify that, yes, we've tried, this lower, like a generic drug, a lower cost drug, something over the counter, whatever, before the MA plan will authorize payment for a more expensive treatment if they feel that the patient can get benefit from one of the less expensive treatments. All right. Plans with low enrollment in existence for 3 or more years cannot renew for 2020. So they've already, that's already been dealt with for them for the 2021 plans. But we know that non-special needs plans that had fewer than 500 enrollees, or special needs plans that had fewer than 100. So what do? We've got some plans who don't have they don't meet that number of enrollees. Well, of course, we're going to have some exceptions for that. There may be that the service area doesn't have a sufficient number of competing options. That when the Part D rule first came out, and the Medicare Advantage as well, that beneficiaries had to have a choice between at least 2 plans in their service area. Well, we know that we've got lots more choices than that in most of our areas, but there might be some parts in Oklahoma that if a special needs plan, for example, was unable to renew, that would mean that there would only be one other plan that may or may not have doctors who have partnered with that plan, who serve those beneficiaries. So we, of course, have these exclusions here so that those plans are not affected. But the organizations, if they're told that they were now going to not be able to renew, they could, of course, appeal that. They need to provide a justification to CMS for that, which makes sense, doesn't it? All right. Here's the maximum out-of-pocket range amounts by plan type. I'm not going to go over this whole chart for you, but you see that we do have voluntary and mandatory out-of-pocket range amounts by plan type. The plan types are listed on the left. And so these are the ones that have been put into place for this calendar year. And of course, this will change beginning in 2021. All right, Medicare Advantage plans and end-stage renal disease. Beginning in 2021, plans can now enroll beneficiaries who have end-stage renal disease. We know that before, if a person presented with ESRD, to be able to join a plan, that was not going to be able to happen unless the plan was like a special needs plan that offered services and providers that could deal with ESRD. So prior to that, we have these restrictions here for MA plans, but beginning January 1 of 2021, a person can then be enrolled in an MA plan or prescription drug plan without these restrictions. All right. Cost plan network adequacy. We know that there have to be a network adequacy for the cost plans, and so we're encouraging improving access in rural areas and telehealth in all the areas with these cost plan within the cost plan networks. So important for folks who live in an area that's more remote, knowing that they do have the option then to improve their access and use telehealth in the areas. All right. Special enrollments for exceptional conditions. We know that there are a bunch that have already been codified, but 2 new ones are for individuals enrolled in a plan that has been identified by CMS as a consistent poor performer. That would then give the beneficiaries in that plan a special enrollment to switch to a different plan if it's not during the open enrollment period. Or individuals enrolled in a plan that was placed in receivership would also have the benefit of a special enrollment period instead of having to wait. All right. Prescription drug plan updates. Let's see. Here's the IRMA chart for prescription drugs for 2020. We know that this will change when information comes out for 2021. But you see that we have the same column for those who file married and have a separate tax returns. Their numbers become effective over $87,000 or more, or over $87,000, and you skip clear down to the bottom for that. But just looking at the prices for the surcharge, really the IRMA amount for the Part D premiums, you see here that it's $12.20 plus the yearly plan premium. All of these go down clear to the highest amount that would be added to the yearly plan premium would be $76. So an important change that can happen for folks, and we've already talked about how we deal with that. Again, the person would need to apply to Social Security if they want to appeal that decision. All right. The true costs, those the costs that count towards your out-of-pocket threshold, will be $65.50 for 2021. And we know that after that threshold, you get catastrophic coverage, and you'll have only a small copayment for that. Your EOB, your explanation of benefits that you receive from the plan, is going to show your true costs to date. And the money follows the patient. So if the person switches plans, that troop amount goes with them. So they don't start over if they start a new plan. They still have that. Your pharmacist can help you know where you are with your troop costs as well. All right. Specialty tiers threshold. We're saying here that, I just got a note, we're running out of time. I'm going to talk faster. All right. There are specialty tier thresholds. $670 is the threshold for 2021 for the full cost of a 30-day supply. I've seen an ad on Facebook 2 or 3 times about a woman who says that the cost of her medication is over $670. And, you know, how is she going to be dealing with that? So important to know for 2021. All right, health insurance marketplace updates. Health insurance marketplace is still with us. It's still alive and well as of today. So we know that all consumers who are in the marketplace are going to get a special notice from the marketplace and from Medicare about their eligibility and changing their health coverage and when's the best time to do that. The periodic data matching, that's for a person who is leaving the marketplace and going into Medicare, and they want to have this premium tax credits stopped. And it's just an authorization for the plan to do that for them rather than the beneficiary taking that responsibility. Equitable relief from late enrollment penalties. This has been since June 30th, this has not been in effect anymore, but there may be somebody who still has a question. So here is a contact number for those folks who need to do that. All the acronyms used. All right, I'm going to quit with the presentation at this point. Ray, if you want to take the screen back, that would be great.
All right. Thank you, Gay. That was great. We are over time, but I did want to ask one quick question. I don't know if you and I will have the answer to this one or not, but regarding the ET3 model, the emergency triage, treat, and transport model, the fact that they're able to go to an alternate location other than an emergency room, the question was, who makes that call? Who makes the decision whether the patient is going to be taken to the ER or to the urgent care center or something like that? The question was, does the beneficiary, hey, please take me to my doctor's office, or is there a professional either at the emergency room or in the ambulance who actually gets tasked with making the decision where they're transported so that, they don't wind up having to pay a bill at the end?
Ray, I don't have that right here in front of me. However, I do have a link that could take me to that. I can get that information to you if you would want to. We can just send out, I guess, a note to the participants today and just answer that question if that's all right.
That would be perfect. All right. And that's really all the questions that we had. So thank you so much. I really appreciate you coming on with us. And you're going to be back with us again in 2 weeks to talk about the Part D prescription drug plans, aren't you?
Yes, I am. I can't wait.
Good. We look forward to it. So to everybody out there, thank you so much for joining us. And we hope you'll be back with us next week when our own Anna Farhall is going to be talking about Medicare supplement policies. So giving you some information about those, some updates that are taking place this year. If you'd like to sign up for those and you haven't already, please go to our website at oid.ok.gov. And we look forward to seeing you. So thank you again for joining us.
Thank you. Bye, everybody.